Good afternoon. Hi, I'm Dr. Mithun. This is Dr. Madhavi Mala. And on top there is Dr. Derlin. So together we'll be talking about Airway. Okay, Derlin will be, Dr. Derlin on top will be presenting on the PowerPoint. Simultaneously, you can see the videos being demonstrated by Dr. Madhavi. Okay, so over to Derlin.
So this session is about our Airway workshop. First, we'll be showing you face masks. So as you can see in this picture, these are the masks which we use for mask ventilation. The first one is the anatomical face mask, and the second one is the transparent face mask. And there are different sizes of face mask according to the size of the patient, and the transparent mask, depending on the size of the mask, it's also color coded.
So she's showing two different types of masks, color coded. You may see the other ones, most commonly the one on the left, the black one. Now she's showing the way how one should hold the mask. That is the CE technique. This is the C part, the index finger and thumb. Then the other three fingers form the E. Understood? This is how you hold a mask. Different types are available. Some, this is how you ventilate with a mask. She's using a self-inflating bag to ventilate now. In most OTs, we have vein circuit or the closed circuit, which has bags, and you can use those bags to ventilate the patient.
And this is the Goodell's oropharyngeal airway. These are also of different sizes and also color coded. And these are the parts of the oropharyngeal airway. Here you can see this is the flange, and this is the bite portion, and inside there is an air channel.
Okay, so this is how you insert the airway. You see that she is holding it upside down, inverted, and inserting it after putting ample amounts of lubricating jelly. And then she will turn it 180 degrees so that it remains in place. This is how you place a Goodell's airway, oropharyngeal airway, or simply an oral airway. This helps in ventilating a difficult mask ventilation patient. And to determine the length of the airway, you can use this technique. You measure from the angle of the mandible to the angle of the angle of the mouth. This is an easy way to measure the size of the airway. Depending on the size of the patient, smaller the patient, you can take smaller numbers, and bigger the patient, you can take higher numbers. This is in short about oral airway.
Now coming to nasopharyngeal airway, it's the nasal airway or the nasal trumpet, and it can be used when the mouth cannot be opened in a patient. So this is also of different sizes. We have to take the size of the nasopharyngeal airway according to the size of the patient.
This is the technique. You measure from the nose of the patient to the tragus, that is the ear. You measure up to the ear tragus, that is the length of the ideal length of the nasopharyngeal airway. This is a soft material, easy to insert, and it is much well tolerated by the patient. Even if it is difficult to insert an oral airway, you can try this nasal airway. Again, it should be well lubricated, and this is how you insert. Some newer ones have a movable flange, so you can adjust the length of the airway. This one is the one without the flange.
Coming to endotracheal tube, these are the things that we need while attempting an endotracheal intubation. We need a working laryngoscope, endotracheal tube with a cuff syringe, and an oral airway. So these are the parts of the endotracheal tube. This is the patient end and this is the machine end. In the patient end, you can see a bevel, a Murphy eye, and a cuff. This cuff can be inflated using a pilot balloon, which is blue in color, and we'll attach a cuff syringe at the end of this pilot balloon, and with that cuff syringe, we'll inflate the cuff. and it also has a radio opaque line, and this is the 15 mm adapter to which we will be attaching the circuit which will be connected to the anesthesia machine. So this is a video of an endotracheal intubation.
Ensure that the equipment is prepared and check that the laryngoscope is working and the cuff on the tube inflates and deflates properly. Pre-oxygenate the patient with bag and mask ventilation for up to 1 minute before attempting
First,
to
we'll
intubate.
be doing a bag and mask ventilation.
Standing behind the patient with the head in the sniffing the morning air position, with the left hand, insert
Following
the
that,
curved
we'll
blade of the
open the mouth of the
laryngoscope into the
patient,
mouth over the right side
to
of the
this,
tongue,
a
displacing it
laryngoscope
to
will
the
be
left
inserted.
and upwards.
And
Advance
the
the
tongue will be pushed
laryngoscope
onto the left
slightly
side.
until the tip of the epiglottis can be seen posterior to the back of the tongue. Advance the tip of the laryngoscope blade into the vallecula between the epiglottis and the tongue.
Once we see the epiglottis,
With the handle
we'll
of the
go to the base
laryngoscope
of the
pointing away from
epiglottis
you at
and
45 degrees,
and we lift the
lift upwards
laryngoscope,
and away to lift up the tongue and epiglottis to display
and
the
then
vocal
we can
cords
see
and
the
the laryngeal opening.
vocal cords.
With the right hand, insert the endotracheal tube from the right-hand side of the mouth
Once you see the
directly
vocal
between
cords,
the cords
you can
and into the
insert the
trachea
ET tube.
until the cuff passes through the cords. The markings on the tube at the incisors will show between 21 and 24 centimeters in the average-sized adult when the tube is in position. Remove the laryngoscope and inflate
the
the
ET
cuff
tube is
with
inside,
approximately
remove the
15 mils
laryngoscope,
of air to prevent air leaking
Inflate
during
the cuff
ventilation.
using the cuff syringe.
Attach the tube to the bag and valve apparatus and ventilate the patient
Attach
with the
to a
oxygen
circuit
flow
or an
on
amber
12
bag
to 15 litres per
and
minute.
see the lungs are getting
Confirm the
ventilated or
position of
not.
the tube by auscultating over the apices of the lungs,
For
the
confirmation,
axillae
we
and
can
stomach.
auscultate at 5 different
If
points.
it is not in the correct position, deflate the cuff and remove the
This
tube.
red mark, at this point, we
Resort back
can't hear
to
any
bag and
sound,
mask ventilation
ideally.
and repeat the intubation process from the beginning. If the tube is in too far,
If
the
you
right
can't
lung
hear
will be
any sound on the
ventilated
left
only
side of the
via the
patient,
right main bronchus.
that means the tube had gone
If this
in more.
occurs, deflate
So
the cuff
at that time,
and withdraw the
we
tube
have
2
to
to 3
deflate the cuff,
centimeters.
pull out the tube a
Reinflate
little
the
more,
cuff and recheck the
then
position.
auscultate again. Once
When
it
the
is
tube is in the
confirmed,
correct position,
again inflate
tie
the
it in
cuff.
place with cotton tape and attach the tube to the ventilating apparatus and ventilate the patient.
Okay, I think you would have understood what the video was mentioning. If the tube goes in too much, it may become endobronchial. Then only one lung gets inflated. So you withdraw it so that you get both lungs getting inflated.
So this is a gum elastic bougie. This is helpful while doing a difficult intubation. So it also has got a patient end as well as, this is the patient end. It has got a curved tip at the patient end. This will be inserted into the mouth of the patient. So once the bougie is in, we'll railroad the endotracheal tube.
The same technique, just like intubation. You introduce the curved tip first inside. That curved tip, the blue image, curved tip inside. And then you're supposed to lubricate the bougie and insert the railroad the endotracheal tube over the bougie. Okay? Okay? And you hold the bougie and the anesthetist can then intubate the patient. And once you get confirmation from the anesthetist, then only you remove the bougie. Again, other steps are similar. You confirm the intubation by auscultation or whatever technique is used.
This is a cuff pressure monitor in order to measure the cuff pressure. So the optimal pressure in adults is between 18 to 25 centimeters of water, while in the pediatric microcuff tube, the maximum we can inflate is at around 20 centimeters of water. And these are the pediatric endotracheal tubes. These are uncuffed tubes, mainly used in pediatric patients. And these are microcuff pediatric tubes. It has got a small cuff at the patient end of the endotracheal tube. And this is a microlaryngeal tracheal surgery tube or MLT tubes. So here you can see the size of the endotracheal tube is smaller compared to the adults, but the length will be comparable to the adult endotracheal tube. So this comes in mainly 3 smaller sizes, 4, 5, 6, and this is mainly used for microlaryngeal surgeries. So you can note that even though the size of the internal diameter, size of the endotracheal tube is smaller, the length will be similar to that of the adult. And this is a preformed ET tubes, and these are of 2 different varieties.
Okay, this is the south pole. This is the south pole tube. South means down south, so tube is directed downwards. The tube remains like this. Tube remains like this, and you can fix it like this, so that the tube goes away from the surgeon's field. Most commonly used for tonsillectomies. And the other one is, this is called a ray tube, ring Adair Elvin tube, ray tube, south pole. The other one is north pole. The one is north pole. This is usually inserted nasally. Inserted nasally, and it remains in this position. Okay. You have to use a laryngoscope anyway. It remains in this position so that the tube is directed upward or northward. So these are the 2 different tubes. That is, one is the north pole, you can see that, north pole one, and the other one is the south pole one. The south pole goes down like this, north pole is like this. I hope it is clear now. See the direction of both the tubes. The upper one is north pole, the lower one is south pole. Next.
Consider this picture on the top portion of the slide. The patient's head is mainly, we take it as the north side and the leg side as the south. So depending on that, we have named these tubes as south pole and north pole. And this is the flexometallic tubes. These are the other names, spiral embedded or armored tube, reinforced tube or flexometallic tubes. It has got a wire mesh or wire reinforced tubes in order to prevent the tube from kinking or any compression of the tube. This is mainly useful in case of head and neck surgeries.
Neurosurgeries also it is employed because you don't have access to the patient, and after a long time these thermoplastic tubes tend to get kinked. But these are kink resistant. You can see that even if you try to kink them, the inside the lumen is never gone. It remains inside. Only danger is if patient bites on the tube, it may cause a kink into the patient. So ICUs, it is not usually recommended. The kink remains if patient bites into the tube. And the difference is compared to the cuff is slightly different. Cuff is slightly different, and you don't have a Murphy's eye. That is a major difference. And you can see the wire reinforced tip. Tip you can see. No, there is no Murphy's eye in this. There is a Murphy's eye in this. It is not there in the flexometallic tube. So it can easily get one-sided ventilation can happen very easily in the flexometallic one.
And since flexometallic tubes are flexible, it is ideal to insert a stillet before we intubate. So this is a double lumen tube. Here you can see it has got 2 tubes. One is the tracheal tube and the other is the bronchial tube. These tubes are mainly used for lung surgeries where we need a one lung ventilation. That if we have to ventilate one side of the lung, we mainly use this type of double lumen tube. And all these, the bronchial tube is color coded, which is usually blue in color, and it has also got 2 cuffs. The bronchial cuff, which is blue in color and smaller in size compared to the tracheal cuff, which is bigger in size. And it also has got 2 pilot balloons to inflate both these cuffs separately. And on the right side, you can see the Y connector, which is used to connect this tube to the circuit of the machine. Now coming to LMA. This is the classic LMA.
You can see the classic LMA easily identified by the color. This is a silicon material. material is silicon material. So the advantage is you can autoclave them. The manufacturer recommendation is 40 times. You can autoclave it 40 times. And most of the data you can see on the tube itself. This is a number 4 used for 50 to 70 kg. Like that you can, number 5, number 3, number 2 is there according to weight. And the maximum number of, maximum amount of air you can inflate is written there. So for a 4 number, it is 30 ml, maximum is 30 ml. And the pressure maximum is, again with the cuff pressure monitor, you can measure the pressure inside, and the maximum pressure inside should never exceed 60 centimeters of water, 60. The method of insertion is quite easy. Lubricate it well using a jelly. She is holding it just like holding a pen. There are different methods of insertion. This is one classic method. She is pushing towards the hard palate. Pushing towards herself, pushing towards the hard palate. The cuff is deflated. Either you can keep the cuff inflated or deflated. Here she has not inflated the cuff and she has inserted. Next step is you inflate it using a syringe. So this is a 4 number tube, so maximum you can put 30 ml. So she is introducing 30 ml. So what happens is, now the LMA seats itself. Now you can connect the circuit and check for ventilation. See that the lungs are getting inflated. So this is how you do an LMA. There are different LMAs available. The next generation is the ProSeal LMA. How do you identify the ProSeal LMA? It has got a separate tube. This is for the esophagus. So when there is, you can insert a Ryle's tube through this. It goes into the stomach, and you can put more air into this pilot balloon. There's difference between a ProSeal and a normal LMA. LMAs are very important because if you are not able to intubate the patient, the next step in the difficult airway algorithm is LMA. So you make sure that whenever there is GA happening, make sure that an LMA is available very close to you. Next one is an intubating LMA or fast track LMA. These are becoming obsolete now because of the arrival of advanced video laryngoscopes identified by the steel handle. Next.
iGel.
Next one is iGel. Here things are much easier because there is no cuff. You can see that there is no pilot balloon, no cuff. The cuff, instead of the cuff, there is a special thermoplastic elastomer gel. So that will seat itself, and its insertion is very easy. You just simply insert it just like an LMA, and the gel seats itself into the oropharynx. Next one is a video laryngoscope. Before video laryngoscope, we forgot about one thing actually. This is our main instrument, that is a Macintosh laryngoscope. That is the laryngoscope with the Macintosh handle. So you have a handle and the blade. The blade contains the light source. Actually here light source is different. Blade contains the light. And this is the commonly used Macintosh blade. Actually, different sizes are available. The anesthetist will tell you which size blade to be used. Next advanced device available is a video laryngoscope. Multiple devices have come now. We have with us we have the McGrath blade. This one is the McGrath video laryngoscope. For this, you need to attach the blades into the video laryngoscope. Now we have channeled ones and non-channeled ones. This is a non-channeled one. If the blade is channeled, then you are supposed to preload the tube into the blade and then insert. You get very good view of the larynx.
This we can see and intubate. We can see the structures inside, and seeing that, we can intubate.
You get very good views of the larynx with this video laryngoscopes. Next.
These are the
This is a-
different types of video laryngoscope.
This one is King Vision laryngoscope. You can see that there is a channel blade and a non-channel blade. If you are using a non-channel blade, the problem with video laryngoscope is you have to use a stylated endotracheal tube. Now, other one is a
Coming to fiber optic bronchoscope.
fiber optic bronchoscope. So this one is a disposable fiber optic bronchoscope. So you connect this electrical connector to the display. So this part will go into the display. And this is the part where you introduce into the patient. And as like doing with the bougie, you first railroad the endotracheal tube into the fiber optic scope. Make sure that it is well lubricated. The next step is the anesthetist will introduce the scope in fiber optic scope through the nose or the mouth, usually through the nose, and she will enter into the larynx. After entering to the larynx, then the tube is railroaded. Tube is railroaded through the over the scope, and then once it is visualized, then you withdraw the scope, and the tube remains inside.
So we have kept 3 mannequins in the side room. So if any one of you is interested, you can come and do the intubation. Try the intubation in that room. Thank you.